when we start with the concept of surgery, a patient comes for a surgical procedure. He is terrified about a lot of things like his disease process and is he going to feel any pain, and what we are going to do with his pain, how we are managing his pain, because pain is a major concern for the patients undergoing surgery. So patient's objective is to get to a routine life after the surgery like he was earlier, whether it is elective surgery or emergency or related to any trauma. So he has concerns that without pain or with pain management and other disease process management, when he is going to start his life again in a normal routine way. Next कीजिएगा. Pain has different physiological responses which affect almost all of the system of the body. Starting from the cardiovascular system, pain increases heart rate, blood pressure, promoting oxygen consumption, and may lead to pulmonary embolism or risk of DVT. When we see the respiratory effects of the pain, they may promote atelectasis, and there is reluctance to cough and deep breathing, which leads to sputum retention and may promote hypoxemia or infection. As far as GI effects of the pain are concerned, it includes reduced gastric and bowel movements, and may also increase to GI infections. Next slide कीजिएगा please. Physiological response of the pain on the neuroendocrine system is also a remarkable thing, which includes the increase in catabolic state of the body owing to increased level of glucagon, which leads to hyperglycemia and may impair wound healing as well, and reduce anabolic state of the body. Next. On the musculoskeletal system, if the surgery is involved on the muscles, it may include the muscle spasm leading to immobility, which also predisposes to DVT risk. And there may be muscle wasting due to prolonged immobility or disuse, which also leads to prolonged recovery. On the central nervous system, there is central sensitization if the pain is not controlled and there are repetitive noxious stimuli, which includes, and if not treated and properly intervened, may lead to chronic pain. And the psychological impact of the pain are very important, as they may start from the anxiety and pain and may lead to depression and chronic pain, sleep deprivation, and they are of major concern if not treated properly during time. As far as the post-operative pain is concerned, its characteristics vary. It may be nociceptive sensitization or somatic pain or referral pain, visceral pain. So there is a combination of these things as well. During the next slide, we will see that not all the surgical procedures have the same level of pain or same intensity of pain. Every procedure is different. It will have different intensity and different types, like we have seen that visceral, referral or somatic pain, and there would be different location of the pain as well. For example, if there is abdominal or thoracic incision, it will have major pain, whereas area involving lesser pain area or smaller incisions will have different. So not all the modalities are to be taken for as a same in every procedure, and it will also not depend upon the surgical procedure as well. It will also depend upon the patient condition as well. Every patient will be individualized. We have to weigh the benefits and risks of every modality. Like pharmacological, if we are going, we cannot go for the same things for every procedure and every patient, and we cannot go for the same intervention for every procedure. Definitely it should be individualized and tailored according to surgery, according to surgical extent, and according to the patient condition as well. Next. So here comes analgesia options. When we start with the analgesia, first thing comes in the mind is the preemptive analgesia. So what do I mean by the preemptive analgesia is before the production of pain, if we block it, it would be called preemptive. Like if we have to give surgical incision, we have to give noxious stimulus to the skin, and then the cycle of the pain is started, we have to block it before that. We can do it by various means like local infiltration by the surgeon, by anesthetist, by any physician treating that patient. If we block that by local infiltration as well, even if we can block it with the spinal or epidural or any nerve block, it would be called preemptive analgesia before it is produced. So it is the best way. Earlier it was considered that if we go for the preemptive analgesia, it will have a lesser stress response, so it will have a better outcome. However, recent literature showed that it is not only the preemptive analgesia which is needed, but it is only a one portion. So it introduces a concept of which is called the preventive analgesia. Next slide. What do I mean by preventive analgesia? It starts from before starting the surgical incision. It also spans the intraoperative period as well, and it goes beyond the intraoperative period and extend to the postoperative period as well, because pain is one point is incision, other point is like we have various stages during the surgery after the skin incision. Like if we are cutting the bone, it is a stimulus, it is a high intensity period during which pain control different modality is needed of many times, like if we are manipulating the dura or any meningeal layer, or we are manipulating the peritoneum, it will also need a different extent. So we have to control that in the intraoperative period as well. And going beyond the intraoperative period, if we go to the postoperative period, definitely the stress is not over and the wound is healing and the patient is needing pain control as well. So concept of preventive analgesia includes the preemptive analgesia as well. It also includes the intraoperative period as well, and it goes to the postoperative period for controlling the pain. So preventive analgesia is a better term to be used and better be controlled for a better patient care. Yeah. So here is a slide regarding to a preemptive analgesia. It shows that the nociceptive input by the skin incision, or if we are blocking that in the C portion like pre-surgical analgesia, so nociceptive input is not so much perceived, and it reduces the hypersensitivity, but it also should span the intraoperative period and postoperative period as well. So what are the targets of preventive approach to the acute pain management? So as I have told that it includes the preoperative period, even days before the surgery and just minutes before the skin incision, including the intraoperative period as well and postoperative period. There are specific factors within these phases contributing to the development of acute postoperative pain. We have to control them. So if we see the mechanism of pain, when a skin cut is given, a skin incision is given, pain starts by transduction, by the noxious stimulus. So this transduction process then goes to the transmission, and it converts to modulation then, and then perception at the CNS level. So we can block, in order to control the pain, we can block in transduction level, transmission level, modulation level, or perception level. We have various modalities for that. Those can be pharmacological or interventional. These includes different NSAIDs or local anesthetics or any other interventions we are going to discuss. So in the treatment of the pain for the operative period, we have different options, which includes non-pharmacological methods, including the psychological reassurance, patient education, and then come the pharmacological interventions in the form of systemic opioids and non-opioid analgesics like NSAIDs, acetaminophen, and other non-conventional agents, whereas some regional anesthesia techniques can also be used and should also be used. With the recent thing which improves the patient satisfaction for pain control is a patient controlled analgesia, in which we are giving the patient the control in addition to the baseline level by the treating physician who gives a baseline level of the pain control by some means, and then gives the patient the liberty to use analgesia as a bolus when needed and if needed and how much needed. So it is called the patient controlled analgesia. So when we talk about the regional anesthesia, in addition to the general anesthesia, then various options come in our mind, which can be broadly classified as central neuroaxial blocks, which include the spinal anesthesia, spinal analgesia, and epidural analgesia, and non-neuroaxial. Non-neuroaxial analgesia include the peripheral blocks. Peripheral blocks can be divided into peripheral individual nerve blocks. It can be like in the upper limb brachial plexus block, in the lower limb lumbar plexus blocks. So it can be a plexus block, it can be a plane block, in which we target the nerves within certain planes. Like in the abdomen, if we see there is transversus abdominis plane in which nerve roots are there and we have to target them. This is a plane block. In addition to that, we have another option which is called the IV regional anesthesia, in which we give local anesthetic in the intravascular compartment, and then it is disseminated in the tissues and numb that area so that pain is not perceived, and it is also used as Bayer block or IV regional anesthesia. Even it may include the local infiltration, which is often used by surgeons as well. So there are various options for the regional anesthesia. If I see the lower limb, for example, we can have different options like spinal, epidural, as I discussed, that these are central neuroaxial blocks, and these have excellent pain management. And apart from the spinal and epidural, which would have a bilateral effect, we can go for in the lower limb lumbar plexus block, or individual nerve blocks like femoral block, like sciatic nerve block. These nerves can be blocked at different levels depending upon the surgical level. If I see in the upper limb, it can be brachial plexus block, starting from the interscalene block, then supraclavicular nerve block, and then infraclavicular, and then axillary nerve block. Even we can block these nerves like radial, ulnar, median at the forearm level as well, or even the wrist block. So we have so many options for the upper limb and lower limb. Even the truncal blocks can be there for abdominal surgeries, as I already discussed that we can block transversus abdominis plane block, ilioinguinal, iliohypogastric nerve block, like pediatric surgeries or urogenital surgeries. We can go for caudal anesthesia, which is again a central neuroaxial block in the form of epidural space, and we can go for only that target area, like for circumcision we can go for penile block as well. So there are a lot of options, or even local infiltration is also considered the regional block. So if we talk about the spinal or epidural, there are various advantages. They give significant pain relief, and special concern is that they reduce neuroendocrine stress response. इसमें जो है ना, जब हम काउंसलिंग कर रहे होते हैं पेशेंट्स की, तो अक्सर औकात जो है ना वो हमारे पेशेंट्स में कंसर्न ये होता है कि स्पाइनल लगा लिया तो जो है ना बैक कभी नहीं जाएगा, तो उसमें क्या एडवांटेज है हमें, और जनरल एनेस्थीसिया का क्यों एडवांटेज नहीं है लेट से। तो उसमें मैं हमेशा से ये जो है काउंसलिंग करता हूँ इस तरह से कि मतलब देयर इज़ नथिंग रिस्क फ्री इन दिस वर्ल्ड, हर चीज़ के बेनिफिट्स और डिसएडवांटेजेस होते हैं, एंड वी हैव टू वे दैट प्रोज एंड कॉन्स एंड डिसाइड अकॉर्डिंगली। बट इफ़ वी सी कि स्पाइनल या एपिड्यूरल के बाद बैक का कंसर्न है, तो उसकी एग्जांपल अब जो हमारी पॉपुलेशन है उसके हिसाब से उनको इस तरह से कि वी यूज़ ऑलमोस्ट 27 gauge needle for the spinal anesthesia or analgesia, and we use on an average routinely we use 18 gauge or 20 gauge IV Brenula. So if the pain of the Brenula goes and is vanished after removing that Brenula, so after how many days it is vanished, like 1 day, 2 days, 3 days. So अगर ये ख़त्म हो रहा है तो 27 गेज के साथ जो है वो बैकिक जो काज कर सकता है वो उससे पहले ख़त्म हो जाना चाहिए. सो देयर इज़ सर्टेन मिथ अकॉर्डिंग टू कि जो है कमर वाला इंजेक्शन जो है वो हमें प्रॉब्लम करता है, तो उसके हिसाब से हमें थोड़ा एजुकेट करना होता है. सो दे आर सुपीरियर टू पेरिफेरल नर्व ब्लॉक्स or even may be superior to PCA in blunting the surgical response if it is given preemptively before the surgical incision, and definitely spinal epidural we have to go for before the surgical incision. And these reduce the incidence of pulmonary complications and other complications as well, like CVS effects and other things. So if we see the peripheral nerve blocks, and it can be a continuous or single shot depending upon the nature of the surgery. If we have a prolonged recovery period, we can go for catheter placement as well in the peripheral nerve blocks, and we can have a continuous analgesia in the postoperative period. Definitely we have to monitor that patient with a special protocol. Advantages of the continuous peripheral nerve blocks would be superior pain relief even with movements like upper limb की कोई सर्जरी हुई है आर्थो की, और उसमें जो है ना मूवमेंट्स भी चाहिए, हमें पेन रिलीफ भी चाहिए उस मोमेंट को, शोल्डर सर्जरी लेग से, तो उसमें जो है हमें कंटिन्यूस पेरिफेरल नर्व ब्लॉक अगर हमने यूज़ कर लिया है तो वो हमारे लिए ज़्यादा एडवांटेजेस होगा. इट आल्सो रिड्यूसेस सर्जिकल स्ट्रेस रिस्पॉन्स बिकॉज इट रिड्यूसेस द न्यूरोएंडोक्राइन रिस्पॉन्स एज वेल. सो इम्प्रूव्ड रिहेबिलिटेशन इज़ देयर, and our main goal is to reduce opioid consumption and its side effects. Definitely we have to go for opioids consumption as well, but it will reduce that thing. So disadvantages of the peripheral nerve blocks can be definitely it requires technical skill as well. It is not that simpler to be performed by everyone. Infrastructure to manage catheters, especially if the outpatient patient we have to go for that. So required technical skills, equipment, like in today's era, if we are going to perform peripheral nerve blocks in the lower limb or upper limb or abdominal or any truncal block, we have to use minimum of the ultrasound which we have here, and we routinely perform these blocks here as well. So these are of less concern to us. So next slide. So if we see the anesthesia type and mortality, there are various studies for different procedures which show that regional anesthesia in the form of blocks will have improved outcome, like reduces the hospital stay, reduces the stress response, improve patient satisfaction, and improves pain quality and mobility or rehabilitation as well. So general anesthesia promotes DVT and also increases the risk of pulmonary embolism. So in general, if we go for regional anesthesia, whether it is neuroaxial or peripheral nerve block, these reduce the risk of DVT and pulmonary embolism and transfusion requirements as well. So these are again different studies for different procedures. Next slide, please. Including the carotid endarterectomy, aortic aneurysms, etc. Next. So if we have seen that there can be pharmacological methods, there can be peripheral nerve blocks, there can be central neuroaxial blocks. So why not go for peripheral nerve blocks or central neuroaxial blocks as a standalone procedure, just as anesthesia? Like if I have to go for a surgery of the upper limb, and can I go for it with only a supraclavicular block, like let's say our interscalene block if it is for the shoulder and upper humerus? So we can, but recommendation is that to place that block we will also need patient cooperation, and also we'll have patient discomfort as well. So we may need to go for sedation as well, or we may need to go for general anesthesia as well. So if we are combining general anesthesia along with any interventions like general anesthesia plus spinal anesthesia, general anesthesia plus epidural analgesia for the major surgeries like laparotomies and extensive surgeries like radical procedures. So what is the additional outcome? Because क्योंकि इसमें पेशेंट यही बात करते हैं कि जब मैं सो रहा हूँ तो फिर मेरी कमर में टीका लगाने की क्या ज़रूरत है, आप मुझे सुला तो रहे हो, जनरल एनेस्थीसिया ही दे रहे हो. तो उसमें यही होता है कि बेसिकली रैशनल फॉर गोइंग रीजनल एनेस्थीसिया अलॉन्ग विद जनरल एनेस्थीसिया इज़ टू रिड्यूस स्ट्रेस रिस्पॉन्स एज वेल। तो उसमें मैं पेशेंट्स को यही कहता हूँ कि देखिए जनरल एनेस्थीसिया तो हमने आपको दे दिया, आप सो रहे हैं, आपको पता नहीं है, बट व्हेन स्किन इज इंसाइज्ड योर हार्ट रेट गोज अप, योर ब्लड प्रेशर गोज अप, एंड वी आर सीइंग दैट यू आर फीलिंग पेन डिस्पाइट वेरियस interventions like we have given you opioid, we have given you NSAID, we have given you paracetamol and other agents as well. Even then skin incision के ऊपर जो है आपका हार्ट रेट बढ़ेगा, ब्लड प्रेशर भी बढ़ेगा. सो इट इज़ नॉट द एंड. व्हेन यू आर गोइंग टू अवेकन, उसके बाद जो वो स्ट्रेस रिस्पॉन्स जो शुरू हुआ था, जो प्रीएम्प्टिवली हमने कंट्रोल नहीं किया था, दैट इज़ गोइंग टू affect you in like sensitization and may increase the threshold of pain and may increase pain in your post-operative period and prolong your hospital stay as well. Of multimodal analgesia. So multimodal analgesia is combining two or more than two interventions. It may be in the form of only systemic things, means it may be in the form of pharmacological drugs, as well as it may be in the form of drugs plus any interventional combinations. So our goal is to provide effective pain relief, reducing opioid related side effect as well, and surgical stress response, and to improve the clinical outcome. So concept as combination various analgesic techniques and different classes of drugs. Basically multimodal analgesia is considered when we use different classes of drugs which affect on different pathways to block the pain. That would be called multimodal. So philosophy of the multimodal analgesia is not only to give just two or more drugs with the different mechanisms, but our target should be one drug. If one drug is affecting in the peripheral sensitization, then other would be affecting at the central sensitization. If like we have seen that from the transduction, transmission, modulation and then perception, if we are blocking at different levels with the different drugs even, or with different interventions, that would be called multimodal analgesia. So basically this would be a rescue thing. If we are blocking one receptor, we have to block a second receptor as well. Like एक इंटरवेंशन अगर मैं ये कर रहा हूँ कि सुप्राक्लाविकुलर ब्लॉक लगा रहा हूँ और उसमें मेरा थोड़ा सा एनाटॉमिकल जो एरिया है वो मेरा ऐसा है, डिमांड कर रहा है कि यहाँ पे थोड़ी सी स्पेयरिंग होगी उस इफेक्ट की, और मुझे जो है उस पर कोई चांस नहीं लेना है, मैं उसमें सीडेशन नहीं दे सकता हूँ लाइक इन सिलेक्टेड केसेस, तो उसमें मैं एक रेस्क्यू ब्लॉक की तरफ जाता हूँ कि लाइक मीडियन नर्व, अल्नर नर्व और रेडियल नर्व इसमें. तो सो वी हैव टू कंबाइन ड्रग्स मस्ट एंड आल्सो द कंबाइंड ड्रग्स मस्ट बी synergistic or additive as well. Some drugs may act at several points at nociceptive pathway as well. Next slide. So according to guidelines for the acute pain management in the perioperative setting is that multimodal techniques for pain management include the administration of two or more drugs that act by different mechanisms for providing analgesia, and these drugs may be administered where the same route or by different routes, or even may include the intervention as well. Multimodal analgesia with different drug combinations, gabapentin, ketamine, dexamethasone or other combinations like paracetamol have a superior quality in controlling the pain. So to conclude, multimodal analgesia improves outcomes in a sense that if we are getting a synergistic effect by different drugs, then we have to reduce those doses required for pain control, and we will reduce their side effects as well because we are reducing the dose. However, we have to keep in mind that if we are using different combinations, their side effects can be synergistic as well. So we have to keep that in mind as well. So if we have improved analgesia, we can mobilize the patient early, we can start feeding early, and it will lead to rapid recovery and definitely reduce hospital stay and improve patient satisfaction, and overall reduce cost for the resources, including the hospital resources and the patient resources as well. So aggressive preemptive multimodal, including epidural or nerve block, not only produce optimal analgesia but also may prevent the occurrence of chronic pain after surgery, because our one aim is to reduce the psychological effects with the persistent pain. If the patient is continuing to feel pain in the postoperative period for a long period, then he will develop chronic pain. So there is a concept of peri-surgical house or home care team. So it involves a multidisciplinary approach. Definitely patient comes to the surgeon for any surgery, whether elective or emergency. Surgeon is the main pillar here. Then comes anesthesiologist who has to administer anesthesia and has to plan anesthesia plan and analgesia plan, and what would be the intraoperative analgesia, what would be the optimization preoperative, and what would be my postoperative analgesia as well. And we discuss with the surgeon as well for the major surgeries that like for some radical procedures or some major abdominal thoracic surgeries, even we coordinate with the surgeons that this patient is going to receive pain management options, and we will need like epidural analgesia in the postoperative period as well. So it would need a preoperative properly planned analgesia plan to improve the patient condition and disease status and its recovery. So it will also need support services as well. So it will start, so our analgesia plan would start from the preoperative clinic, and for some surgeries we may need physical therapy and psychological support to the patient as well, like if we are going for some arthroplasty, and it needs to be it needs a lot of patient education as well. So starting from the preoperative thing, we will evaluate the patient, we will educate the patient, and we will optimize the patient for any thing which is to be optimized before surgery for the better outcome. And then comes the intraoperative period, in which we will include the enhanced recovery protocols, which will include also the preemptive analgesia thing, and definitely every patient for every surgery would be an individualized plan we will devise according to the needs of the plan, according to the needs of the patient condition and the surgical condition as well. So in the postoperative period, we have to facilitate recovery, plan discharge, communicate, and education and ongoing care, not only from the postoperative period. It will also, this plan which is called the perioperative surgical home care team, this will also extend to the rehabilitation phase as well, which will be the post discharge status of the patient. We will send the patient, let's say we will send the patient at home with the painkillers and with instructions. Definitely we don't want him to suffer like that. So here is a proper plan, including from the preoperative assessment, preoperative optimization, intraoperative thing, and then postoperative plan. So this was all about regional anesthesia. So in short, just to conclude, that we have discussed not only pharmacological methods we use for the postoperative or intraoperative pain management, but we can combine them with interventions, and those will would be starting with the preemptive analgesia, and then we would stop the pain before it is produced, and then we will continue our care in the intraoperative period as well, and we will continue our services in the postoperative period and to the discharge and even discharge as well. So thank you all.
Dr. Shahbaz, I enjoyed your presentation. Nowadays, people are using ultrasound machines and other things. So could you enlighten us about this?
Yes. Dr. Zafar has asked that regional anesthesia is being promoted so much in today's era. People are going very ambitiously for the regional blocks as well, because central neurological blocks are already being given. But in today's era, everyone is posting on the social media that we are doing this regional block and that. So we are also doing regional blocks here for every procedure where it is indicated and where it is justified and where it is needed. So among the newer techniques, if I go for the lower limb, definitely along with the other nerve blocks, adductor canal block in the lower limb is a relatively newer technique. It is performed on the medial side of the thigh for the femoral nerve. Here it is termed as a saphenous nerve for knee arthroscopies like and knee arthroplasties. Its extra advantage is that it does not affect the mobility of the knee. So mobility of the patient is needed after knee arthroplasties. So it is a desired thing. If I go for the thoracic area, then pectoris major, pectoris minor, pec 1, pec 2 blocks, and then serratus anterior block, like these are the newer techniques. If I go to the truncal area, then erectus spinae block is the newer technique. These are the individual nerve blocks which are newer, which I told. Just overall, in today's era, everyone has changed concept towards the use of ultrasound because of the safety profile with the ultrasound, and with this, that we have learned that patient satisfaction and patient analgesia and patient outcome is improved by all of these newer techniques and newer modalities. Everyone is after this.
Any new drug which has come up which is more safer than what we have been using in past, like lidocaine?
So there are various drugs. If we are talking about any local anesthetic or any adjunct, like in the adjuncts in nowadays, dexmedetomidine and alpha-2 agonist has come up with the recently blown up thing that it is safer and can be used in the blocks as well, and as a sole analgesia as well and anesthesia as well. Some other drugs are also there, like in the hypep things, dexmedetomidine I think is the newer drug.
Can you go to the slide transduction and transmission slide? Okay, Shahbaz, you mentioned transduction, like we preempt and we do preventive analgesia. When you mentioned steroids and coxibs and all those things, at what point these things are given? Like, in the preoperative day, in day before, night before, at the time of induction, like when do you introduce these, the corticosteroids, NSAIDs and coxibs?
Sure.
अभी इंसिजन से पहले लगाना है या ये हम शाम को देते हैं, कि किस स्टेज पर ये आपको लगता है कि इफेक्टिव है?
Right. So here comes a question by Dr. Ahmed that certain drugs as preemptive analgesia, when is the timing to give those drugs to effectively produce that preemptive analgesia? So there are various things like steroids and other NSAIDs or opioids. These are, if we are going for general anesthesia, definitely these are given just prior to surgery according to induction protocol. But there are various studies, even we have conducted a study here with the use of pregabalin preoperatively, not on the day of surgery, but perioperatively for arthroscopies, and continuing at to the postoperative period as well, and it showed significant results with the reduction of postoperative pain management. So, if we are using various drugs like pregabalin and others before the it will include the, I would say, preparation period of the patient. So these will have effect. Basically, if we see the mechanism, then definitely if it is affecting on the central sensitization and it is affecting the neuromodulation, let's say, so we will give that drug preemptively even before the day of surgery. We can go for that. But if it is it affects on the system where just it affects transduction or transmission, then locally or anything, then definitely there is no point giving it 1 day or 2 days earlier. Then definitely just before the start of the surgery we can start with it. Even IV lidocaine, we go for that to reduce the surgical stress response for abdominal surgeries as well, and we start it before induction. Like patient is on the operating table and we have to start induction when we start IV lidocaine, and it will continue in the interpretive period as well, and it has showed significant reduction in stress response and patient analgesia as well. As far as steroids are concerned, steroids affect multiple levels. So they can be used preoperatively as well, intraoperatively and postoperatively as well, but we have to see their side effects as well on every system. So judicious use would be appreciated. And any other drug? Like if we are going for local anesthetic or local infiltration, then definitely we can go for it intraoperatively or postoperatively as well. But if we start it as a preemptive, then it would be having much more effect, but only then if we don't stop it as preemptive only. We will continue to in the it to be in the intraoperative period as well as in the postoperative period as well, just as a continuum of that preventive care.
Just a small question. Like bupivacaine versus charotene, is there any improvement in that? Is there any benefit? Charotene better है या एक जैसे ही है?
Bupivacaine versus
Charotene.
Charotene is levobupivacaine.
Levobupivacaine. So levobupivacaine is basically isomer of the bupivacaine. So it has some better outcomes. Rest I am not remembering this, so I pass it to Dr. Jamal. That's like
स्टडी हुई थी टोटल नी रिप्लेसमेंट पे, और इसके अलावा एक दो पेपर्स पे और हम काम कर रहे हैं लेकिन आउटसाइड द हॉस्पिटल, इसमें स्टेनोटमी के ऊपर स्टडी हो रही है. सो फॉर दोज पेशेंट गोइंग फॉर कैबेज, इनको हम 1 hour बिफोर 300 मिलीग्राम गाबापेंटिन से लोड करते हैं एंड देन पोस्ट ऑपरेटिव यूज की ऑपरेट कंजम्पशन हम ऑब्जर्व करते हैं. तो गाबापेंटिन, केटामीन, लिग्नोकेन इन्फ्यूजन, मैग्नीशियम इन्फ्यूजन, इसमें बहुत ज़्यादा ना प्रिवेंटिव एनाल्जेसिया का काम हो.
ये आईवी वाली भी इंटरेस्टिंग है. मैं लीड्स में था तो वहाँ पर ट्रायल भी चल रही थी. 2018 की बात है. आईवी लाइडोकेन. हाँ, तो वो उस पर ट्रायल्स कर रहे थे उस वक्त. अभी ये तो अब इस्टेब्लिश ऑब्वियसली आप बता रहे हैं हो गया होगा.
सर इसके लिए कि इस तरह की यूरोपियन सोसाइटी ऑफ पेन एनेस्थीसिया ना, उसकी काफ़ी वो है प्रॉस्पेक्ट स्टडीज हो रही हैं. बहुत ज़्यादा मेटा एनालिसिस करती है हर सर्जरी कि इस पे कौन कौन से प्रीएम्प्टिव है, कौन से इंट्रोवर्ट, इसकी रिजल्ट्स हैं that can be used. Those people, I can share it with you.
So basically, it is IV lidocaine has an established role for abdominal surgeries, and they have a significant established role.